Dear panel, dear audience, welcome to the very last session of Progress Reports. We've come to the beginning of the end. I'm going to talk about contemporary alignment techniques in total knee arthroplasty, and shortly you will understand what this means. I'm a first-year PhD student and a third-year resident in trauma and orthopedic surgery from Székesfehérvár. Naturally, I'm interested in the management and treatment of osteoarthritis, and I have a special interest in total joint replacements. So, during my PhD, I would like to compare two techniques in total knee arthroplasty, first by conducting a systematic review and meta-analysis, and then running a randomized controlled trial. So in my first project, I'd like to compare the safety and effectiveness of kinematic alignment and mechanical alignment in total knee arthroplasty. Globally, about 500 million people are affected by osteoarthritis. And I'm talking about total knee replacements. Guess which one is the most frequently affected part of the body? It's the knee. And up to date, the standard treatment, the gold standard for treating painful, debilitating knee osteoarthritis is total knee replacement. In the US alone, about 800 million total knee replacements are done each year. But the problem is about 1 in 5 patients after this operation are not very satisfied because of some residual pain or other symptoms such as instability. And it's a problem. It's a big number of people, and they are essentially left with a bad, painful knee. They most often have to learn to live with it. And the other problem is that we don't know what is the reason that so many people are unsatisfied after the operation. One theory is that it's related to the alignment of the implant. Alignment is basically the relationship of the implant to the axis of the bone. And we've been using traditional mechanical alignment since the 80s, pretty much unchanged, because it's easily reproducible, it's safe, effective. The problem is it's a little bit of a one-size-fits approach, and in theory, and it doesn't take into account soft tissue tensions and ligament tensions in the knee. So this could induce strain in the knee and pain. Now this is why newer techniques have been developed, such as the kinematic alignment, which are supposed to be more personalized, where they take into account these ligament tensions and they adjust the position of the implant. So we want to know which one is the best alignment technique in total knee replacements. This slide, I just want to show you quickly. I really like it. It's a one-page summary of my PhD topic. In one corner, you have mechanical alignment. In the other corner, kinematic alignment. And if you notice, mechanical alignment is associated with rectangle, with perpendicular angles, straight lines, and then kinematic alignment basically have no boundaries. So two essentially different approaches, and in between, you have these slightly modified versions of each. In my project, I'd like to ask, is this new personalized approach actually superior to the traditional mechanical alignment in terms of pain relief, improved function, and reduced morbidity associated with the surgery? And my hypothesis is that, yes, it is associated with better results. We've conducted a systematic search in 3 databases using 3 domains, one for population, one for intervention, and one for the comparator. And after duplicate removal, we were left with 2,200 results. We've completed with my selection pair, András, the full text, the title and abstract selection, and we currently have 93 articles to do the full text selection on. So. We hopefully we aim to finish this by next week. In my second project, I'm going to talk about, I would like to compare the safety and effectiveness of one of these modified inverse kinematic alignments and mechanical alignment in total knee arthroplasty by designing and conducting a randomized controlled trial. So, as I've discussed, there is a shifting paradigm in the world of total knee arthroplasty, in which we are moving towards more personalized approaches. And this is also reflected in the fact that we've seen a steady rise in the use of robotic-assisted technologies. And there is, since 2017, there has been an increase from 2% to 16% in the use of robotic-assisted technology in the US. And I'm lucky enough that I can regularly work with one of the surgeons in Hungary who uses one of these robots. And essentially, we can measure and capture data during the operation about the knee. We can measure the soft tissue and ligament tensions of the knee during the operation. We then import this data into a computer where we can plan and personalize. We can come up with a personalized plan for the positioning of the implant. And this plan is executed with a robotic cutting guide for precise execution. This approach is called inverse kinematic alignment. But it's a new technique. It was introduced in 2020, and there hasn't been any direct comparison with this and the traditional gold standard method. So the question is this new fancy technology worth its money? Is it worth investing? Do patients actually have less pain, better function after surgery? And my hypothesis is that yes, but we want to find out. Based on a preliminary research, there have been some comparative cohort studies and even a simulated computer study, but we can see that there hasn't been any RCTs comparing these two techniques directly. However, there is one trial registered from Australia, and which means that I'm not the only one who thinks it's interesting. And who knows, maybe when these two trials are done, someone can run a meta-analysis in CTM. So hopefully by now you understand what I mean when I talk about contemporary alignment techniques in total knee arthroplasty. Essentially in my PhD, I'd like to compare a traditional and a new technique in total knee replacements, first by a meta-analysis and a systematic review, and secondly by running a randomized controlled trial. And I would like to finish my presentation with a quote from Albert Einstein: "Learn from yesterday, live for today, hope for tomorrow. The important thing is not to stop questioning." But that's not true for the next 4 minutes. Thank you.
Thank you for the great talk. So, questions, please.
Okay. So, congratulations on your presentation. My question would be that can you use kinematic alignment technique in revision surgeries as well, or not?
Great question. Currently, it's not recommended for revision surgeries. It's only recommended for primary surgeries.
What's the reason for this?
The priority in revision surgery is different. We want to, there is not enough evidence for the safety of this new technique in revision surgery, and the risks are high in revision surgery. So we want to go for a mechanically stable knee that stays in there and doesn't require further revisions. Whereas the revision with kinematic alignment is the risk of revision is not yet known clearly.
Okay, I see. Thank you for your answer.
Thanks. Right side, please. Yeah.
Yes. Can you do this traditional mechanical alignment with robotic intervention? Is that a possibility?
Yeah. So you're asking whether the traditional method can be actually done with the robots, and yes. And there have been studies that compare the manual and the robotic version of the traditional mechanical alignment, but it didn't show any significant results actually. So probably the change and the improvement is not simply achieved by the robots themselves or greater precision, but the alignment and the personalized approach that we can achieve with robots.
Thank you.
So this inverse kinematic alignment sounds a good choice for me, but what are the financial implications and how much longer is the surgery when we compare it to the traditional method?
Great question, thank you. So usually the surgery is about 5 to 10 minutes longer when we use the robot for this technique. It's not considered significant. And financially, at the moment, this technique is only available in private hospitals, so it's quite expensive at the moment.
Audience didn't have any coffee in the coffee break, or what's going on here? Okay, then let me ask the question. You want to prove a kind of superiority at your second project, to prove the higher cost and higher time, and what is the superiority? What you would expect, and in what percentage or numbers? Because at the very end, we want to show it to the health fund or to the patient.
Yes. So we're chasing that remaining 15 to 20% of people who have painful knee after knee replacements, and so our primary goal and aim is to and hope is that we can reduce the number of people who have pain after the operation.
To half, or what is your hope? You're optimistic.
Well,
hope.
Our hope is that
is to zero is
that no
impossible, but
close. Yeah. So somewhere above 95%. Somewhere compared to hip replacements. Hip replacements are excellent. They are great, and we want it to be comparable to hip replacements.